Thank you, Mr. Chairman. Thanks to the organizing committee for the kind invitation. And I would like to congratulate them for the outstanding event you are having here. Though the title of this presentation, HIV cases, will be presenting only 2 cases. Probably it's a misleading title. But I believe both of them are very interesting cases. The first one is a challenge we face every day, those of us who are dealing with HIV patients. Part of it is patient's mistake, and the other part is related to the institute rather than the physicians. So the first case, these are true scenarios. A 40-year-old gentleman who presented in June 2007 as first presentation, diagnosed to have PCP, and it is first time to be diagnosed to have HIV. His CD4 count at that time was 40. The viral load was 500,000 copy per ml. The genotyping of the virus showed a fully sensitive virus, so he was started on a triplet. 4 months later, he was seen for follow-up. He was doing very well. His CD4 count was 180. The viral load was undetectable. In another 4 months' time, he came for his routine follow-up, again asymptomatic. However, it has been noticed that his CD4 has dropped to 110, and the viral load has increased to 50,000 copy per minute. So what is the next step? What shall you do? Sorry? Change the regimen? Who will change the regimen? Sorry?
Someone said here check compliance.
Aywa.
Doctor said
Resistant. Okay. So, no new medication has been added, so most likely it was compliance. And more important than doing genotyping is counseling. So he was counseled again, and it was stressed for him the importance of compliance. Genotyping has been done, and it was found to be resistant to efavirenz. So the regimen has been changed, and the new regimen has been to compavir and Kaletra. Again, you know, I usually refer my patients from the first visit to the psychiatry. However, I can say with confidence that 70% of them declined to go there, and he is one of them. So he was switched to compavir, nilfanavir. Importance of compliance has been clearly explained to him, and the risk he is running at by not adhering to the medication of creating resistant virus. 4 months later, he was seen, again doing well. CD4 has increased to 160. Viral load was undetectable. Unfortunately, in July of the same year, his CD4 has dropped to 90, and the viral load has increased to 80,000. The genotyping has shown that the isolate of the virus is resistant to most of the protease inhibitors. So what shall we do? Again, you know, it was recounseling, intense counseling. Psychiatry referral again declined, and based on the sensitivity, he was started on raltegravir, darunavir, ritonavir, and DDI.
Was he non-compliant?
It is interrupted treatment.
He was non-compliant with second regimen.
Exactly, yes. Yes, in all the 3 events, it was poor compliance. And what is worse, he lost follow-up after the last visit to report about 2 years later with oral thrush and 8 kg weight loss. So what shall we do now? Shall we put him back on the last regimen, or what shall we do with him? The patient was clinically stable, though he was having oral thrush. So shall we give him fluconazole alone? Fluconazole with antiretroviral? Who will support giving him fluconazole alone? Fluconazole, only one. Okay, right? And who will give him fluconazole and heart treatment? Okay, that's not bad. About 10 people. The rest are. Those who will give him heart with the fluconazole, what regimen you will use? Was it the first one or the last one? The first one, the triplet. The last one, raltegravir, and its colleague. Okay, since the patient is stable, it was elected actually to just give him fluconazole to treat his thrush and to repeat the genotyping for him. So what do you think the repeated genotyping, any idea? The repeated genotyping after almost 1 year of more than 1 year of antiretroviral showed that it was a fully sensitive virus. So he was switched back to AAA, intense counseling again, and fortunately he was seen again, and it's about 2 years now under regular follow-up. The viral load is undetectable and his CD4 is above 160. So the message behind this case is patient education is very important, though it doesn't work all the time. You know, we know our culture and we know our people, and sometimes what happened to this patient is not his fault also. We know that in several occasions there is interrupted supply of drugs, and we run out of certain medication, so we have to switch back and forth between the medication. And the other important message that these viruses keep changing their sensitivity. Even if they're resistant in the beginning, don't give up on them. You know, if you have a patient who insert a regimen, and for one reason or the other, either the virus itself has mutated, or it was the interrupted treatment created a resistant virus, you change to the regimen. If they mutate again, go back and do genotyping, maybe the sensitivity has changed. The other case is also a quite interesting case, but it is different from the other one. It's not uncommonly seen. We don't see much of these cases. And this is a 26-year-old gentleman who is known to have HIV since 2004. He was not on treatment. At that time, he was diagnosed in Syria when he presented with abdominal pain. September 2009, that was his first presentation to our hospital. He came with odynophagia, epigastric pain, diarrhea, candida esophagitis, gastritis, and stool showed that he was having cryptosporidium. CD4 was 20, and his viral load was 500,000 copy per ml. The genotyping showed a fully sensitive virus. After intense treatment in the hospital for 2 weeks, he was discharged in very stable general condition. He was on AAA, prophylactic Ciptra, and Losec for his stomach. 3 or 4 months later, he was seen for follow-up in the clinic. He gained 8 Ks. There was no complaint at all, doing very well. He's back to his normal life. His CD4 has increased to 350, and the viral load was undetectable. Then he lost follow-up for more than a year. February 2013, that was about 3 months back, he presented to our hospital with about 15 Ks weight loss, odynophagia, diarrhea, severe right chest pain, and dyspnea. Cough, productive yellowish sputum. His CD4 was only 9, and his viral load was 800,000 copy per ml. This is his chest X-ray. Some CT cuts here. You can see there is a large cavity and mediastinal mass. And again, this is different cuts. So the most likely diagnosis is TB. Anybody who's seen TB before would say 90% this is a TB case. And this was confirmed actually, or at least this is the report of the CT scan. It says that compatible with an acute infection which is predominantly involving the right lung with enlarged necrotic mediastinal node and parapneumic effusion on the right side. TB would be a primary concern. This is the radiologist's opinion, and the clinician, we all agree with that. So, any other differential diagnosis? CMV? Right. Yeah, okay, we agree. The cryptosporidium, but any other differential diagnosis for the lung itself? Fungal? This is not the picture of aspergillus. Cryptococcal neoformans may involve the lung, but it is more localized and pleural effusion. Candida? Candida, usually it is either small nodular in particular area or diffuse, and diffuse usually is a fatal disease. They don't come. They're very sick. Sorry? Sorry? Nocardia. Hhokail, yes. Hhokail is a possibility. His CD4 is 9. Toxo involving the lung is, in this picture, is very unlikely. Most of the toxo cases usually is meningoencephalitis. Yes? Lymphoma? Lymphoma, okay. But this is a large multi-cavitary lesions. Could it be lymphoma complicated by secondary infection? Is a possibility. But lymphoma يعني, causing these multi-cavitary lesions is less likely. So our initial impression that could be TB has been supported actually, and the sputum was 4+ for AFB. The blood culture was growing gram-positive rods. So, and it is not one sample, it's more than one sample. So this could be, which one? Listeria. Okay, listeria is a differential diagnosis, yes. Though in the blood more likely is Corynebacter probably, okay, which is diphtheroids. And that was the initial impression from the lab that this is diphtheroids. So based on this thing, very classical radiological picture, suggestive clinical setting, 4+ AFBs, initial diagnosis of TB has been entertained, and he was started on 4 drugs. Corynebacterium is the most likely organism in the blood. Vancomycin was added. So if it is Corynebacter, because it is more than one occasion, the one of concern you will be worrying about is which one of Corynebacterium? Hhokail, okay, and Hhokail because of concern of endocarditis. But after starting the treatment, next day the lab called, and this AFB is not Mycobacterium tuberculosis based on the DNA testing. And we know that the specificity of the DNA for MTB is 99+. In that case, what shall we do? Mac? So we have 2 choices. Either we keep the anti-TB and expand the spectrum or the coverage, or change the regimen completely to MOT coverage. That is mainly focusing on MAC or cancer CI, because these are the most serious thing in those kind of patients. Again, because of the clinical setting and the classical radiological situation, we said, okay, we'll cover both. So treatment was expanded, and amikacin, Clasid, Cipro was added to the previous regimen. We continued to do daily blood culture on him, and for 7 days he continued to grow gram-positive rods in spite of being on vancomycin and this broad spectrum. So what is the, sorry? TE, okay. TE was done and it was negative. Next. And I have to say that he had as a baseline chest, abdomen, pelvis, CT, and the only pathology was seen in the chest. Bronchoscopy? Why? The sputum is giving you bugs, you know, it's 4+. I didn't think that bronchoscopy. Anybody would support bronchoscopy? Sorry? He doesn't have central line, no. Okay, so we have an explanation actually for his persistent bacteremia, but we are not sure of it. So we went ahead and we asked for white blood cell scan, which is endium scan. However, the radiologist suggested that we do it for gallium. I am from the old generation. We used to do gallium in the past, and I thought it is phased out, but they said no, it's there. So we did for him gallium scan, and the gallium scan came to be negative only for the chest where the focus is. He doesn't have any hidden infection or cryptogenic abscesses anywhere. So now what shall we do? Why persistent positive blood culture? We went to the lab and we spoke. Sorry? What is that? Vancomycin? The problem is we were not able to get sensitivity on that isolate from the blood. Okay? And now what makes it worse? No, we have very well-qualified microbiologists and said we could not do sensitivity on this isolate. They failed, they could not. So after 1 week, with gram-positive in the rod in the blood that is not identified, the sputum is still persistently positive for AFB. We went to the lab and we sat with them and told them what's going on. And this is unusual for us. So they said we'll give you more piece of information. The isolate you have in the blood is the same what you have in the lung. It is the same bug. It is not corynebacteria. And what is in the lung is not mycobacteria even. It is not mycobacteria other than TB. It is not a moth. So what on earth is this bug? Nocardia? Well, yeah, we told them, could this be nocardia? They said, no, it is not a nocardia. Could it be actino? They said, no, it is not actino. So what is it? Which one? Listeria? No, Listeria doesn't stain AFB. And it's Rhodococcus. Okay, this, we asked them, we said, okay, this is the only thing we left with. They said, Bacillus, no, Bacillus doesn't stain AFB. It is gram-positive rod, but doesn't stain AFB. So we said, okay, Rhodococcus is, probably will match with all these things. They said, this is not Rhodococcus. And we said it is an uncommon organism, probably you missed it. They said we had a CAB survey 6 months back, and those working in the lab know what does the CAB survey mean. And they said we have been given Rhodococcus, and we identified it. It's not Rhodococcus. Yes, they said that, and it is easy to know, and also biochemicals, it's not very difficult to identify. The patient continued to have fever. He's having positive blood cultures. He's on very broad spectrum. Anything to add? Anaerobes. What anaerobes? يعني هي الأكتينو. الأكتينو probably يعني that may stain positive. Legionella. What about it? Is it gram-positive rod? No. Anyway, we asked them to send the organism out for further identification, but we have to do something for the patient. So what we did, we added for him imipenem to cover also for other organisms which is not covered by the, though he's on amikacin, which is very strong gram-negative, but probably because he's having necrotic tissue and abscess, it's not penetrating there, so we said we'll give him the benefit of doubt. In 72 hours after starting the imipenem beside the others, he starts to respond from fever-wise, his temperature starts coming down, and in about 7 days, his sputum has converted, start to penetrate from 4+ to 2+, and for the first time we got on him negative blood culture. So once we get with the lab, and now we are sure that we are not dealing with mycobacteria with a typical or atypical, INH and pyrazinamide has been stopped. He was continued with rifampicin because of its broad spectrum, and we added for him imipenem. And then what is next, as we said, the TE and the others. And in 2 weeks' time, the isolate that has been sent out came up with the diagnosis. So what is this bug? وين الميكروبيولوجيست؟ ها؟ طيب شوف طلعونا الميكروبيولوجيست الحين هم اللي بيعطونا الجواب. ها؟ You are our microbiologist. Tell us how can we identify these things? I mean, how come it was not identified?
Is it growing at the same time? Like that's how the classes grow, like 5 days, 6 days? They grow rapidly?
No, for this one, for our isolate to grow within 70 to 96 hours. It's not that long.
I'm going to throw a very sporophrex or the aerosol was bacteria. Aerosol phrex was the question. Aerosol phrex was the bacteria.
It is the last day and the one before the last session. I know you will be surprised that it turned to be Rhodococcus actually. Okay, so it was Rhodococcus equi. طيب احنا we are giving you the sequence. الميكروبيولوجيست قلنا لهم يعني this is the only thing and it's compatible actually. فقالوا لا, this is not Rhodococcus. The lab could not identify it. So يعني we keep scratching our heads and that's why we stretched our treatment. We covered everything. Okay, Rhodococcus equi is very rare actually, or infection. And talking about myself actually, for more than 20 years experience, I have seen only 4 cases. It is non-common infection in the HIV patient and it can come up in different range. We still have time, so we can give you a quick review about Rhodococcus equi. But before we do that now, the patient is sick, and this is another interesting point. He's on broad-spectrum treatment. His CD4 is very low, his viral load is very high. So when shall we start his antiretroviral treatment? Shall we start at time of 0, or now he's almost a week on treatment, or 10 days, or shall we wait? A, B, C. A starts as soon as possible, B start now, C start later. A, who will support A? Support A? Huh? C4, wait for another 3-4 weeks, you know. Yeah. 3-4 weeks. A. Okay, so A, B. B, that is يعني in about a week of starting treatment, or more than 2 weeks, 2 weeks and plus. Okay, and the concern is iris. Okay, it's immune reconstitution syndrome. There are several studies has been done in this area, and especially most of it is on TB. And the recommendation is, if the patient is, it's better to wait at least for 2 weeks after starting anti-TB treatment to minimize the risk of iris. And the lower CD4 you have, the more chance you will, the patient will develop iris. This is again severe infection. The iris reaction is a severe infection. Studies has been done on TB, but other serious severe infections, including severe PCP also, has been studied. And that's why you delay, you give steroid even sometime in early situation. This isolate was in vitro sensitive to amikacin, erythromycin, doxycycline, ciprofloxacin, imipenem, resistant to vancomycin. So the vancomycin was stopped and was continued now on imipenem, amikacin, ciprofloxacin, classid, and recently we added for him doxy because he developed renal impairment. So the amikacin was stopped. The patient shows very good clinical response. He is afebrile, very stable. However, we're still having problem with him after 2 months of treatment, still having bad lung disease with poor radiological improvement. The pleural effusion have to be drained. We put a pleural catheter there, and it turned to be culture negative. Another problem with him is severe bone marrow suppression. Bone marrow showed hypocellular marrow. There's no granulomas, nothing. So very quick review for the Rhodococcus. 5 minutes only? Okay. And this review has been done one of our fellows, Dr. Basim Basha, and I appreciate his effort in that. The microbiology, Rhodococcus equi is a facultative intracellular, non-motile, non-spore-forming, gliomorphic gram-positive coccobacilli. It is stained AFB weakly, pair similarity to diphtheroids, and that's why our isolate in the blood has been identified as diphtheroids. The primary cause is zoonotic infection. It comes from the horses. And this man actually have a farm, and he used to go there. He came from Syria, and chronic suburethral pneumonia, lung, bronchial lymph nodes, abscesses, ulcerative colitis, mesenteric adenitis, all have been reported. Infection in human was first reported in 1967. In 1980, as usual, the microbiologists have changed their classification, and that's a problem we're having with microbiology. They change name and classification every while and then very frequently. So they changed it to Rhodococcus genome, and the group, it's part of the group Phrenocardia actinomyces. It grew in different media, including Colombian agar, pH, Lone, Johnson, and this is how it's stained on the gram stain. It's gram-positive rods, though it could be gram variable, and that's the problem with it also. I will not go through that. There are 27 different polysaccharide capsular serotyping, and the fastest way is to do the API. However, sometimes you have to do more sophisticated tests like what happened with our patient to get to the full identification. The mortality, let's go to the 3/4 of pathogen isolates have been found to contain 15 to 17 kilodaltons. It is a granulomatous reaction disease and profound impairment of cell-mediated immunity, like what happened with advanced HIV, is the most important. It's seen also in other immune-compromised transplant patient who is on steroid or other immunosuppression that involve the T cells. Between 1967 and 76, only 7 cases has been reported. Most of them are on corticosteroid or cancer patient. There are renal transplant, 1 patient, and all have recovered. Between 77 and 86, there were 15 patients has been reported. 1 of them was alcoholic, renal transplant 2. There was HIV 7 patients, and other are cancer patients. Between 87 and 96, there were 93 cases. And most, or the largest number was in the HIV patient. Again, the epidemiology, as we said, it's mainly from the farm related to the horses. And it has been reported from almost all over the world, from United States and Europe, Asia, Mycobacterium diphtheroides. The risk factor is immune suppression, immune deficiency syndrome, age 78 patients with HIV, 71, this is in 1 study has been reported. The mortality rate was very high actually in these patients. Where is that? We are running short of time, so I'm trying to cut it short. Clinical presentation, pulmonary, usually primary site of infection, sputum, bronchial washing, and tissue abscess content. All these can grow the organism. It is subacute in onset, and the symptoms, most of the patient will have fever, prominent fatigue, chest pain, malaise, chronic or relapsing course. It could affect other part of the body, including the eyes, the brain, or the abdomen, the intra-abdominal disease. The differential diagnosis, as we said, lung abscesses, metastatic CA, Mycobacterium avium, nocardia, pneumocystis carinii, PCB. That is based on the radiological, mixed radiological and microbiological. Some of them does not match microbiology. And sputum, gram stain, and culture in patient infected with HIV have pulmonary involvement, usually positive in 60 to 100% of cases. In stool culture could be positive in Rhodococcus, although in our patient it was negative. And this is the classical chest X-ray or CT finding you will see of them. They cavitate usually. Treatment is mainly medical. There are some study about the surgical involvement, like in our patient, because he's having large necrotic area and large pneumonia. We spoke to the thoracic surgeon about also excising this area, especially after 2 months of intense course of treatment. However, their opinion that he's very high-risk patient and he will fistulize and probably he will not tolerate that. From the medical point of view, it is usually guided by in vitro sensitivity. Most of the isolates are sensitive to rifampicin, macrolides, carbapenems, and the others. Combination with treatment is advised, especially if there is synergism, such as amino glycosides and carbapenems, especially in the first few weeks. It's advised to give at least for 6 weeks with parenteral treatment, then continue treatment. Duration is not clear. If it is mild to moderate, probably 2 or 3 months will be adequate. Severe cases, you may go beyond 6 months. Patients like ours with this severe disease, probably it will be much longer than that. There's a slide, probably we skipped that. I don't know where is it because we are running short of time, but the mortality rate has been reported in HIV patients with very low CD4, around 55%. In immune-competent people, there have been reported very few cases, and mortality low is extremely low. Other immune suppression, like cancer patients, steroids, something around 25%. Thank you very much.